I'm Christos Apostolidis. I'm an anesthesiologist here. And my aim for today will be to open a window to anesthesia practices. And we will talk about the target, the essential target of our anesthesia techniques, which is the brain. I'll go to the next one. Okay, so in the previous Congress, we talked about cerebral oximetry. In this one, we will try to say something about electroencephalography. What is actually an EEG? It is a window into a brain's oscillatory state. The pyramidal neurons in the cortex, they're very nicely aligned, parallelly aligned, and they produce action potentials, local field potentials, which are depicted by the surface electrodes, and they give us a display of positive and negative deflections of specific amplitude and specific frequency. But the cortex does not act by its own. It is interconnected with the deeper structures, the brainstem. So the EEG actually gives us a global understanding of how the brain works. Now, monitoring of the depth of anesthesia, this is what we started actually looking, how deep a patient is anesthetized in order to minimize intraoperative awareness. And this is the correct meaning, this is the correct terminology nowadays. We talk about patient awareness because no one really knows what happens in the brain during an anesthetic. But what we can quantify actually is how aware was the patient during the operation. And we started developing these monitors because there were many claims from patients, especially when total intravenous anesthesia was used, that they were aware during the operation, especially when they were deeply neuromuscularly blockaded, so they could not actually react and show us what the problem was. So this is how we place those electrodes. We can do it either ipsilaterally or bilaterally. And we get an EEG, which we cannot actually read as anesthetists. We have to be neurologists to read it. So we can use a Fourier analysis and get these 5 waveforms. We can see from down up the gamma and beta waves, which are fast and small waves. These are the waves of the awake patient, the awake patient with blinking eyes, and moving upwards where the waves are taller and slower. These are the waves of a patient who is asleep, especially the alpha and the delta waves. So what did the IT guys did is they took the EEG and they did a bispectral analysis. The net result was to get an index, just an index, a numerical index that would characterize a patient as being awake or asleep on a range of 0 to 100, 100 being awake, and 40 to 60 of a patient being under surgical anesthesia. Now, this index is essentially dimensionless. It is there regardless of the age of the patient or the anesthetic he is under. So all these monitors came, and these are different monitors, but they say the same thing. It's the same index. It's either a BIS index or a PSI index or the entropy index. It's essentially the same thing. So we tend to lose the index and dig into the EEG, to the processed EEG waveforms, so that we can understand how the agents act. And again, I would like to stress that again. We do not know how much the patient is asleep. We cannot measure the depth of anesthesia. We can quantify the level of awareness, and we can see whether our agents that we use are actually working where they're supposed to be working. So this is a decomposition of the patient, of the EEG of a patient who is awake. We see on the A the patient is awake, so he has beta and gamma activity, small and fast waves, and then he starts to be inducted into anesthesia. So we go from B to C. C is a sedative state. We see alpha and beta oscillations. This patient can be drowsy. He can undertake, for example, an MRI, but there is some recollection of the events. And then we go to D, where you have the surgical unconsciousness, where you can see this sine wave pattern. This is the delta waveform, and on top of this are small oscillations, which are the alpha waves. This is the concept of surgical anesthesia that we know nowadays with most of our anesthetics. And moving on, E is a deeper state, and I will show you just the F. Just have a look at the F. This is the burst suppression. It is essentially a flat EEG, which is interspersed with some bursts of brain activity. And we will talk about this shortly afterwards. So moving on, we came up with a density spectral array, which is a very, very fancy way to look at things and be the smart guy in the OR. We can display the whole thing as a plot of power. You can see the C over there, a plot of power or increased activity over the frequency. So in this patient, we see increased power in the slow waves, the theta waves, and the theta waves, as I said, and the alpha waves. The second peak is the alpha waves. So this patient is probably under anesthesia with GABAergic agents. Or we can display it, as you see on the bottom, in a 3D reconstruction. It's actually 2D, but the third dimension is the color. So you have on the x-axis the time, on the y-axis we have the frequencies, and the color depicts the power. So as we can see, we have increased power in the theta territory and increased power in the alpha territory. Okay, so and low powers in the high frequency awake state territories, the beta and the gamma, as I said. So the resulting display is this one. On the left, you have the Massimo monitor. On the right, you have the Covidian monitor. So what do we see here? We see some clues about the EEG on top. We see the number, the numerical index, which is there. And we can see it's about 72. And on the bottom, we can see the digital spectral array, the coloring. So you see there is increased activity in the theta territory. So if we dig into that, we can see this patient is under sevoflurane anesthesia. So from the left of the screen, you see there is a dense band of increased activity in the alpha and theta territories, which is they are really activated. So the sevoflurane works, and moving on, they start to open like a zipper. This is the zipper effect, and so you see increased activity in the awake territory. So beta and gamma waves start really picking up. So the patient starts to wake up. Okay. This is what we get from most of our anesthetics, the GABAergic anesthetics. This is what we get. So why should we bother look into that? We bother because besides being a fancy monitor, it gives us the opportunity to titrate our anesthetics according to the patient we have, no matter how old or how young the patient is. And it really monitors our way of working. So we can be more precise. We can avoid over or under sedation and the burst suppression that I showed you in the beginning. What is burst suppression? It is depicted here as these black vertical lines. It is a flat trace. It is essentially an isoelectric EEG interspersed with some bursts of activity, and it's possibly associated with post-operative delirium or cognitive decline or increased morbidity and mortality. I would like to say that I would like to blame cognitive disorders or neurodevelopmental disorders in our children later on in life in this effect, but the evidence is lacking. No one really knows if there are any repercussions for our patients after this burst suppression. So you can see it here. In the Massimo, it's much more, the lower scheme is Massimo monitor. There are these black vertical lines. You can see them clearly. And the BIS monitor is a bit more difficult, but you can see maybe a blue line going down until the theta, up to the theta activities. So lots have been said. Many people have looked into this, but there has been no decisive, no causal effect of the burst suppression in the neurological status of our patients afterwards. But we can use this monitor as a surrogate hemodynamic monitor because we experience cardiac arrests, we experience deep hypothermic cardiac arrests, so we can monitor whether the brain is in the state of suppression or not. So whether the brain is metabolically inactive or not, so that it can be protected from this arrest. So I will move on to a case, a very interesting case report that it's a patient that we had it was a female patient for a thoracoscopic closure of an ASD, and while she was on bypass, which was an uneventful bypass, we noticed that there was this decrease in the BIS index, and as you can see, the brain shut down. We have low power in all territories. We started looking what was going on. The bypass was very nice. We had no problem with that. But we noticed that the CO2 sampling line was blocked. So we took an arterial blood gas, and as you can see, there was an increase in carbon dioxide, 99.5 millimeters of mercury. So there was an insufflation of CO2 in the thoracic cavity because we had a thoracoscopic operation. The atrium was wide open, so the carbon dioxide was absorbed in the venous circulation, and then we had this depression of this EEG, so CO2 narcosis, as we say. Later on, when we tended to the issue, to the matter, we removed the carbon dioxide, or we reduced its insufflation rate. PCO2 fell down to 51, and as you can see, the brain started working again. This would not be evident with any other kind of monitor, not even with oximetry, as we can understand, because oxygenation was perfect during the case. And this is a case of intraoperative ventricular fibrillation in an off-pump cardiac case. there was a left main stem disease, and there was the patient had a VF, intraoperative VF, which was really quickly, swiftly tended to, and you can see this pause in the DSA, which is actually a burst suppression. So there you go. Now, we can titrate our anesthetics according to the patient's biological age. So you can see on the left, you have a young patient, 22-year-old patient. On the left, you have a 59-year-old patient with quite an aged brain. So you see there is diminished alpha power, which is the mainstay of aging on the brain. We have diminished alpha power, you see. And what happens to our young patients? Young patients less than 4 years of age, they have no myelin sheaths. So there is no alpha power in the beginning of their life. So if we have an EEG monitoring of these babies, then you see a complete absence of alpha power up until the 4th month of age. And let me stress that we're only looking through a small window. You see, this is what a normal EEG should look like. But we only look at the front of the head of the patient. This is a nice picture of a baby, 5 months of age. You see abundant alpha power, abundant power throughout the whole spectrum. And we can actually see how our drugs are working, how our anesthetic drugs are working. So this is a typical propofol case. You see a train rack. This is a train rack, increased alpha and delta power. The patient was awake, as you can see in the beginning. He was awake, and then the patient is awake in the beginning, so you have increased power all over, and then he was induced. So you see loss of beta and gamma activity, and we start having this train rack kind of activity with alpha and delta waves. Okay, and what happens here? The patient starts slowly to wake. See increased power in the beta and gamma territories. So what the anesthesiologist did, he just gave another bolus of propofol, and he went into burst suppression. And following that, we start having a normal propofol kind of pattern, and then the case ends, and we wake the patient up. The same thing is with inhaled anesthetics. Well, the band is denser in inhaled anesthetics. A different action is with NMDA ketamine, NMDA factor ketamine. You see spindle activity on the beta territory, and dexmedetomidine, again, spindle activity. So we can know, the anesthesiologist now can know by just having a glance on the monitor, on the DSA monitor, he can know how his drugs are working. So it is an additional information for us. So here you have all the different characteristics of our drugs. So I would like to say that we can have a prognosis of, we can use all this new information for prognosis, but sadly we can't. There are not very many studies that come and give us new insight. But I think that the future is bright, and that there are other things that we can find out with the CNS monitoring, such as, for example, how is the hemodynamic status of our patients. So it can be used as a hemodynamic monitor. So thank you.